Spinal cord injury refers to any damage or trauma to the spinal cord. There are many causes that could result in spinal cord injury, such as car accidents, fall, violence, and sports injuries. These are most common causes for the spinal cord injury. So, there are two types of injuries that can be involved into spinal cord injury. One is direct mechanical damages into the axons, and then neurons become disconnected from each other. But also, after direct injury, the surrounding tissues around the spinal cord could become swelling and then compress the spinal nerves and the circulations, and then cause permanent damages to the nerve cells. So this could take 72 hours to show up for the symptoms related to different levels of injury. So doctor usually need to wait 72 hours, and then they can make final diagnosis. But also patient could have some other complications from injury, such as hematoma, hemorrhage, ischemia, infarction, hypoxia. So all these could be the complication from the spinal cord injury. There are several terms that you need to get familiar with. For example, paraplegia and tetraplegia refers to different levels of injuries. For the paraplegia, usually injury happened to the level for T1 and above and below, and then patient will have paralysis of the lower extremities, but usually upper extremities still the sensory function, the motor function can be intact. For the tetraplegia, usually the injury happened to C8 and above, so a patient could develop paralysis of all four extremities. So the levels of the injury is very important for you to differentiate what is a para and what is a tetraplegia. And also another pair of concepts are very important: spinal shock and neurogenic shock. Spinal shock, more like mechanical shock, usually happen right on the scene. It's just disconnection between the brain and the peripheral nervous system and the internal organs. So everything become flaccid, muscle become flaccid, all of flexes are gone, and loss of sensation, and also the bladder bowel lose control, and patient develop urinary retention and constipation problem. Usually the injury, all the symptoms that happen to the area below the level of injury. For example, if a patient got the injury on like T6, and then all the injury, all the symptoms will show up below T6. And neurogenic shock, incidental shock is usually a temporary shock, though. Usually happened, can get recovered within 24 hours. But we do have some patients that could become permanent on some flexes and paralysis. For the neurogenic shock, it's more like a circulatory shock. Usually, what happens, the patient lose the vasomotor tone in the blood vessels, and then patients start to develop hypotension and bradycardia. Hypotension is more common, and also all the blood pulling into the venous system. So when you touch a patient's skin, it kind of gets really warm, and usually this happen to T6 or above. Usually it's a kind of high level spinal cord injury, and this also is life-threatening, need emergency treatment, emergency care, such as need to give atropine, dopamine, and fluid replacement to help keep vital signs stable. So it's very important. Mechanisms of the injury, this picture also is shown in the textbook. So just kind of show you the different types of injury, like flexion injury and the hyperextension injury. This kind of injury could stretch the ligaments, which is kind of like surrounding the spinal cord to protect the spinal cord. So and these ligaments become ruptured and then cause direct damages to spinal cord. For the compression fracture, it could happen when patient tried to dive, but the water was too shallow, and or patient fall, and then the compression fractures crush the vertebra, and the small fragments could damage the spinal cord, and small bone fragments could crash into the spinal canal and cause direct injury to the nerves. And also the last one, flexion rotation, is most dangerous one, the most severe injury. For example, one patient was in the car accident. The car was hit on the side. The patient could have flexion position, like a picture showing A, but also could have a rotation. So kind of like a torture of a spinal cord ruptured and stretching over the spinal cord. So your spine will be unstable. Next picture shows the level one, just is kind of will show you like different levels of spinal cord could the injury to different levels of spinal cord could cause different symptoms. For example, here C5 to C7 and T12 to L1. This is the most common injury site. It makes sense because these are like neck area and waist area. This is most flexible position and involve a lot of movements and less protection from the trunk. So, but when we look at the levels, if injury happen to C4 or above, a patient will lose, become paralyzed on the respiration. And patient need to be intubated and need to be on the ventilator. If we happen to see if we happen to see 3 to C5, which is the area controlling diaphragmatic respirations. So patient tend to develop hypotension, hypoventilation. And also C5 is controlling fine movements on the fingers and hand positions. So if a patient develop an injury at C5, a patient may have a trouble holding cups and doing some fun activities. And also for the thoracic nerves, from T1 to about the T7, controlling the chest muscles that will involve if a patient develop injuries to this area, patient could have trouble with the breathing in terms of the muscle movements, and patient will have hard time to remove the secretions from the lungs, and could have a risk of pneumonia. And from T8 to T12, controlling abdominal muscles and the lumbar nerves, L1 to L5, controlling the leg muscles. So any injuries to this area, patient could develop some problems with standing and ambulation. And S1 to S5, controlling bowel and bladder movements. When patient develop injuries to this area, patient could have a retention, urinary retention, and constipation during acute stage. and also this area involves sexual functions too. And on the right side of the slide, this is showing like different areas of spinal cord controlling different functions. For example, anterior area of the spinal cord control voluntary motions such as contraction for the muscles, try to lift, try to walk. So these are voluntary motions. And also on the side, like part of the side lateral position and also anterior area of the spinal cord, also taking care of for proprioception, pain, temperature changes, light touch, and the pressure, and also on the lateral side, also control the voluntary motion too. On the back of the spinal cord, responsible for proprioception, deep touch, and vibration. By the way, proprioception refers to truncal stability. So if a patient get injuries in these areas, patient on the posterior of the spinal cord, patient could have a fall risk, and patient cannot have a good balance on the posture. So this is also very important for you to know these different type of syndromes. Of course, the first one is a complete deletion. That means a complete damages to the whole spinal cord. So patient lose all the function of motor function, sensory function, flexes. So when, for example, like this picture shows, if a patient get injury at L1 level, and then patient will lose function in the levels below L1. So patient lose motor function, sensory function on the legs, so lose all the tendon reflexes on the legs, so on and feet. For the central cord injury, in syndrome, usually injury happen to the central area of the spinal cord. Usually this is happen when patient develop over extension position, hyperextension position on the cervical spine. And it's more common to see the motor dysfunction like paralysis rather than the sensory problems like numbness, cannot feel any pain, and also usually happen to upper arm, upper extremities more common, and then the lower extremities. And for the anterior cord syndrome, it usually happen to the anterior area of the spinal cord, which is control of voluntary motion and also pain and temperature changes. So patients tend to have motor problems, paralysis, and cannot feel any pain, cannot control the temperature. But patient should have no problem with the positioning, vibration, and deep touch sensation, which is taken care of by the posterior part of the spinal cord. And for the brown sequard syndrome, it's interesting. When patient get hit on the left side, the patient will lose all the motor functions and vibration, position function, deep touch position on the left side, which is the damaged side. But patient will lose sensory of pain and the temperature, light touch on the right side, which is the opposite side to the injury. It's very different. And next was the conus medullaris and the conda equina syndromes. They're very similar because they all taking care of bladder and the bowel functions. So one patient develop injuries in this area in the L1 to L5, S1 to S5, patient will lose control for bladder and the bowels. But for the conus medullaris, because they also involve T12 and T11, so patient also could show some symptoms in the lower extremities, lower legs. Okay, so we talk about the different levels of injury, And now we change it to another angle to look at in general, if we go by body systems, so what kind of clinical symptoms a patient could show up. And also, I recommend you to look at the figure 61.6 and the table 61.3 and 4. These tables are very helpful for you to get familiar with the different levels of injury to the spinal cord and what are the corresponding problems, symptoms. Related to the clinical manifestations are related to the level and the degree of the injuries. And for example, is which level on the spinal cord, and is it complete or incomplete in spinal cord injury involvement. Usually, when the lesion, the injury level, if it's a higher the lesion level on the spinal cord, usually more severe the consequence from the injury will be. So, for example, for the respiration, if an injury happen to C4 and above, patient will lose respiratory functions and need a ventilator to help with the breathing. If it happen to C4, usually like C4, C5, patient will have hypoventilation problem because the patient are using diaphragm to help with the breathing. And also patient will have depressed breathing efforts and hard to remove the secretions from the lungs. Patient tend to develop atelectasis and pneumonia. If injury happened to T6 or above, patient could have neurogenic shock, which is characterized by bradycardia and hypotension. But also cardiac circulation also can be like circulating problem. For example, blood clots like DVT and the PE could be complications from spinal cord injury. And urinary body system also can be involved, and this is one of the very, very common symptoms that could happen to most the patients regardless of the level of injuries. Because the connection between the brain, the area that control the bladder functions in the brain, and also the connections between brain and the bladder become disconnected. And I mean also bladders become disconnected, and then patient could develop urinary retention at the acute stage. We call that flaccid bladder. But during the recovery stage, a patient will become incontinent because spasticity in the bladder muscle, detrusor muscle, and the patient tend to develop incontinence, and which is a spastic bladder. And overall, we call this a neurogenic bladder. And the GI could be involved. T5, if injury happened to T5 and above, a patient could develop a paralytic ileus and gastric distensions. And also because of stress, a patient could develop GI ulcers and GI bleeding. If injury happened to T12 or below, and then patient will develop constipation at the acute stage and incontinence in recovery stage, similar to the urinary problems. Just in the acute stage become flaccid. All the reflexes are gone, but in the recovery stage, and the nerves become spastic and very sensitive to any pressure. And then cannot control the sphincter muscle, and they just keep losing the stools. Peripheral vascular problems involve DVT and the PE, just because immobility So need to watch for the side effects, the symptoms of DVT and P. Integumentary also can be one of the issues, complications from the spinal cord injury because of the immobility. So patient could develop pressure ulcers, and also because um, there is a loss of connection between the hypothalamus and the peripheral nervous system sensation functions. The body cannot control the temperature by sweating or dilate the blood vessel. All these measures, so a patient will not be able to regulate the temperature if the room temperature is too low or too hot. Patient's body temperature will be too low and too hot because hypothalamus is supposed to control, regulate the temperature, not to be too high or too low. But now patient cannot have that function anymore, so patient have a risk of either hypo or hyperthermia. For the collaborative care, first of all, need to look at this table 61-5. This is emergency care. Definitely, you want to go by ABC and assess the degree of the injury. And very important, you need to keep your head and the neck in neutral position, immobilize the patient. And I just show you a video how to immobilize.
This is the spinal mobilization skill for the supine patient. First thing I want to do is I want to make sure I have my BSI on, my gloves as well as my goggles. Next, I'm going to have my partner here take manual stabilization of the head and neck. Please don't let go until I tell you to. Next, I'm going to check pulse motor and sensation in all four extremities, checking bilateral pulses, bilateral grips, and also sensation by feeling her thumb and forefingers and making sure that she can feel me touching her. I'm going to remove the shoes and socks. I'm going to check bilateral pedal pulses. I'm going to have her push up and pull down against my hands. And I'm checking sensation of toes, big toe, little toe, so that she can feel me. So that's all intact. Next thing I'm going to do is I want to size and fit the appropriate collar, C-collar. So I'm going to measure the C-collar. She's about 3 fingers. I'm going to adjust the collar to fit the patient. Lock it in place. I'm going to deploy the chin strap and place it on the patient. I'm going to place it on the patient with minimal movement of her head and neck. Next, I'm going to have my partner come in and we're going to log roll the patient. On your count, sir, we're going to log roll. Please place one hand on her shoulder, one hand on her hip, and we're going to cross arms like this. And on your count, we'll log roll.
All right, on 3. 1, 2, 3.
Okay. And sir, could you check her back for injuries, decaf BTLS? I'm going to bring the board in, and we're going to log roll her back on your count.
1, 2, 3.
And it looks as though she needs to come down and to the right. So on your count.
So to immobilize a patient, you need a cervical collar and also backboard to keep a patient's whole body immobilized and keep them in good alignment, and use log roll technique to move the patient, to transfer the patient. But we do have some contraindication or debates about the necessity of immobilization for patients during the pre-hospital stage. The studies showed the patient who went through the immobilization process, just like the video shows, that process, actually they tend to have higher mortality rate compared with the patients who was transferred by the private vehicle and who did not go through the immobilization process. So kind of you need to just kind of be aware of that. But so far, still immobilization for the neck, and local techniques are the standard, like gold standard protocol for emergency care for the patient who have a spinal cord injury. But like the table also shows for the patient who have a penetrating type of injury, uh, it's not necessary to have immobilization of the neck. Um, the same reason, because a patient in more critical condition, doing this immobilization could cost more time and waste the valuable time. And also it looks like it's not really necessary to immobilize the neck if a patient have penetrating wounds on the head, on the body. So um, not like other mechanical injuries. You want to keep a good patent, airway, check ABC, vital signs, but most important, definitely we need to send patient to surgery to decompress the spinal cord, the pressure to the spinal cord, um, and to treat the injuries. And also there are some many medications need to be involved in the treatment of spinal cord injury. Corticosteroid medication used to be a classic protocol to control the edema. Remember when we talk about secondary injury to the spinal cord injury, usually swelling of the surrounding tissues of the spinal cord could be a major contribution to the further damages to the spinal cord, spinal nerves. But the study shows actually corticosteroid cause more, because of the side effects from the corticosteroids. Actually, patients tend to have more problems, develop more complications from the medication. Um, so in clinical, um, the current protocol is, if the injury happened to within 8 hours, it's okay to let patient to use a corticosteroid to treat the edema. After 8 hours, you really need to decrease or need to stop using corticosteroid medication, because the side effects like increase the risk of infection, GI bleeding. These already have been problems with the patient who had a spinal cord injury. So atropine, dopamine, and fluid replacements for treating neurogenic shock to maintain good vital signs, to keep systolic blood pressure above 90 millimeter of mercury, and help to treat bradycardia, like atropine treat the bradycardia, and Lavanox for preventing DVT and PE. Um, Immobilization of a spine. Later on, we can do the bone traction, skeletal traction, like this picture shows. Insert the pins into the into the skull, and then through the pulley, we can connect with the weight to help maintain the traction. The purpose of the traction is to try to maintain, immobilization of the spine, immobilization of the cervical spine, and also help to maintain good alignments, um, and also prevent the dislocation. Um, and some patients may need to wear the halo fixation apparatus, which is kind of like jackets, and patient can wear that, and the patient will have some pins inserted into skull, but also connect with the jacket on the body, so patient will not be able to move the neck, but patient will have no problem with ambulation. So but very important to educate patient, the family member or caregiver, about watching for the signs of infections on the pin side, and also watching for the skin breakdown under the jacket. Um, and to prevent any injury, any damages to the skins. For the pin side care, usually different hospital have different protocols. Usually need to use normal saline, sterile normal saline to wash the clean the wound, and put the antibiotics ointment, um, to help with the prevention of the infections. The fluid electrolytes also could have imbalance problem. For example, if a patient have trouble, like could develop a paralytic uterus, so we need to insert the NG tube to help decompression in the GI tract, and the NG suctioning could result in sodium and low sodium level and the low calcium level, uh, like hyponatremia and hypocalcemia. So need to watch for electrolytes level from the labs. For the fluid nutrition, patients need to take a high protein, high calories to maintain their high energy consumption during the injury. For nursing management, during acute stage, we need to conduct ongoing assessment on these body systems. Respiratory always priority to watch, and doing the suctioning and keep good oxygenation, and you can do the chest physiotherapy, just push or doing massage from the xiphoid process, and push upward, uh, and help to remove the secretions. For the cardiovascular functions, prevent DVT and PE by other measures like compression devices, sequential compression devices, tight holes, like stockings, and you can do the range of motion, help patient with ambulation exercise, watch for the signs of DVT and PE, monitor for neurogenic shock if a patient have injury at the T6 or above, and watch for the bleeding signs too. Bladder, for the acute stage, because patients tend to have urinary retention problem, we can do indwelling catheterization and intermittent every 4 hours to do the catheterization to help empty the bladder. Recovery stage, we can do bladder training, because the patient develops spastic bladder, and we ask a patient to do some bladder training, like hold urine, exercise the pelvic muscles to help strengthen the sphincter in the urethra, and also build up the habit of bladder detrusor muscles in the bladder, help to help with the extension of the muscles, train the habit of urinating regularly. For the GI, if patient have injury above T5, patient tend to have a risk for paralytic uterus or stress ulcer, GI bleeding, and these problems can be treated with NG tube to do the decompression, and patient can take H2 receptor, histamine receptor, like Reglan and Pepsid, helping to decrease acid level, and also can take Protonics, Lepronto, uh, frontal pump inhibitor, such as protonics and Perlosac, to help empty the stomach. And watch for bleeding sign by looking at the red blood cell hematocrit, hemoglobin level from the labs. And if injury happened to T12 or below, patient could have incontinence problem. And during the recovery stage, so you want to check the bowel training programs, let patient take a high fiber diet, keep hydration, and treat patient every morning after breakfast, 30 minutes to 1 hour. Patient need to sit on the toilet for 15 minutes to train the habit to have bowel movement regularly. Do ambulation, stool softener also very helpful. Temperature regulation for the patients who have problem with um, in disconnection between the hypothalamus and the peripheral sensory functions. The patient could have a hyper or hypothermia, and keep patient in warm temperature and watch closely monitor the room temperature. And the motor and sensory functions, extremities, be aware patient may not be able to feel any pain or report any pain because the patient loses the function for sensing pain. Um, and then they cannot report to you, so you need to identify any like your skin breakdown or any damages or injuries to the muscular or skin. And patient could have hyperreflexes, um, and need to educate patient family member. This is not indicating good recovery yet, but just the hyperreflexes and the spasms due to the lack of control from the brain. Um, so it's not return of the function. Yeah, for the spasms or spasticity in these reflexes, and the patient could take some medication to treat the spasms, such as Dentrium. Um, the last one is the autonomic dysreflexia. Usually, this is happen when patients start to get recovered, and sympathetic nervous system getting the function of a sympathetic nervous system are back, but the parasympathetic nervous function not back yet. So what happens is when patient experience any stimulation from the skins, from some internal organs, and any discomfort that could cause the responses from sympathetic nervous function. So patient will have an increased blood pressure, but because usually parasympathetic nervous function is responsible for um, counteract the functions of sympathetic nervous system. But now because the parasympathetic nervous function not back yet, so patient cannot control the hypertension. They just the blood pressure keep increasing, but the parasympathetic nervous system cannot control the hypertension. But because there is a sensor from the carotid, sinus, and also aorta, um, they can sense the hypertension and then stimulate the parasympathetic system and result in the bradycardia. Um, but bradycardia cannot, but the blood vessel cannot be dilated to decrease the blood pressure, so blood pressure still being high. So usually when this happen, usually the lesion is at or above T6. And the causes could be the triggers, could be distended bladder, bowels, and or any discomforts to the skin. And the patient will sometimes they don't tell you. Sometimes they feel like I just feel really hot, like a flash on the face, and I feel really bad headache, or just feel funny. So the major characteristics of autonomic dysreflexia is include hypertension, bradycardia, and headache related to the hypertension. So the treatment usually you want to verify your diagnosis. If you know patient have a history of spinal cord injury, and now patient have a complaint about bad headache or any other discomforts, or you see patient face become really like maybe sweating or feel hot, or feel really anxious or have developed nasal congestion, nauseous. And first thing you want to do is check vital signs, especially check blood pressure to see if the blood pressure go up. If a patient does show hypertension like 180 millimeter of mercury or even higher, like over 200, that will help to confirm patients having autonomic dysreflexia. So next step, you want to prevent a stroke or any other accidents due to the hypertension, because this is high life-threatening situation. So you want to elevate head of the bed 45-degree or let patient sit upright position, and then you check, identify, and eliminate the stimuli. It could be the sheets too tight and you want to loosen the clothing, the sheets. And if it's a bladder problem, distension problem, if a patient's on the indwelling system, catheter system, you want to check for any kinking on the catheters. Make sure the catheter is patent. If a patient is not in having the catheter, you want to insert the catheter, but you want to make sure put some kind of anesthetic um, medication in the urethral area, and then you insert catheter. Same thing happen to when you try to empty the bowels. You want to put a lidocaine into the rectum to numb the in certain area, and otherwise further stimuli could make the symptoms worse. So you want to numb the urethra or rectum, and then you insert the catheter or help empty the bowels. And also you can assess skin for any pressure ulcer. If the systolic blood pressure more than 150, that way we want to give a patient medication to treat hypertension. Usually we have protocols and the parameters that doctor already ordered, and then we can give this medication. That way you can notify doctor, because this is a life-threatening situation, but always keep in mind you need to take action, do assessment, verify your diagnosis, and then help decrease the blood pressure by elevation of the head of the bed, and identify the stimuli and help eliminate the stimuli. So you need to do all these as a priorities. There is another table, table 61-8, just remind you autonomic dysreflexia could happen to recovery stage and could become a permanent chronic conditions. Patient live with it, so it's very important education patient and the family caregiver about identify the signs of dysreflexia, how to treat it, and how need to report to the doctor. So this is just to show you the example. So patient have injury, spinal cord injury at T6, and so the connection between brain and the internal organ become disconnected. So when the bladder is full, the stimuli will stimulate sympathetic nervous function and then increase the blood pressure. Patient become hypertensive, and also the aortic and the carotid sinus can sense the hypertension and then to compensate that by decreasing heart rate. So that's why patient develop bradycardia and hypertension. But because the parasympathetic nervous function not back yet, so they cannot counteract the hypertension problems though. So that's it for spinal cord injury.